presentation is actually a very practical one. I'll go through what happened to me in one case, but it's not very rare and can happen, and we have to be, vigilant as to how to. This patient who was in his mid-60s that had his ischemic heart disease diagnosed and underwent CABG in 2013. And in 2019, I did his LET and RCA angioplasty at that time. Then he came back in June of 2022 with redoing, but this time we tried to minimize the number of stents, and I put the drug-eluting balloons. Now, hypertension, lipemia, and diabetes is the main complaint problem. Central obesity and heavy smoking never stopped. His diagnosis is as follows: coronary artery disease, progression involving the LAD, and question about RCA. Lima not recruited. Patient had a patent saphenous graft with a totally occluded circ, occluded SVG to RCA. Receiving RCA calcified disease. Significance, while with apparent small vessel disease, runoff was not clear. It is really just, as it appeared to me initially, just diffuse distal disease. Now, patient presented recently with a complaint of dyspnea on effort with a chest pain for 3 months, 2 to 3 months. Echo revealed his usual ejection fraction of 40%. And his labs initially were unremarkable. Other labs include sodium, potassium, creatinine, drop I was normal, but up to 210 after the procedure. Triglycerides elevated, although he's on the very high dose of purified omega-3, yet still unable to make it down to normal. His LDL is underestimated, but anyway, total cholesterol is reasonable. His treatments are included the following. You can see Vascepa is my new intervention treatment since few months, which I recently increased to 2 grams twice a day in order to control his triglycerides, and the rest all of usual anti-lipid, antihypertensive, Luthirox for hypertension. Now, this is exactly what's going on. Patient have any tips as to how to run? We were running just a while ago. Okay. Sometimes I noticed if I have to stop and share again. Should we do that?
Can we do stop and reshare it again in order to run the video, please?
Yeah, because it's now not running.
Okay, the audio visual. Stop and reshare.
Yes, no.
Dr. Zubaid, Ramesh Dagubati here. I think you're in the laser pointer mode on your screen, on your pointer. With the cursor.
Remove it. How do I share? Okay, share again. Not running.
End the show, and restart it again. End the show.
Remove the laser. Okay. How do I remove screen? Pointer options. I need to cancel. Okay, oh, yes, it's showing. All right, so this is,
No, click the play button. Yes.
okay.
Okay.
This
Thank you,
is
Ramesh.
what's
He's the one
happening.
who solved it for us.
Thank you. This is how it showed for the left coronary angio. Come on. Doesn't. Where is this? Okay. You can only see the LED. I can only see the LED as it is, totally occluded circ. And if we go to the next, you can see the LED runoff is diffusely diseased. Compared to his previous angiogram 2022, the LED runoff was much better. So this is the only change from before. If we look at the extended view of the LED, you see again a progression of disease distally, and actually between the two stents previously deployed, there was haziness. And this is his right coronary artery. From the first look, I thought not much is happening. Compared to his older angiogram, I thought that PDA is worse, and the PLV branch is also worse. So this is what my initial impression. But look carefully before I injected how the coronary appeared. Again, I'll rerun it. Look at the coronary before. It will be, you'll see it is, there is a drawing of the artery of stents and calcifications. And this is the saphenous vein graft that's viable to the circ, which is, as usual, it was normal. So functioning properly. And at that time, I said, okay, the nuclear test was positive, patient is symptomatic, let me fix his LED, which I did. I pre-dilated with what I called my system is escalating balloons, starting from very small to medium size, maximally, still I use 2.25, sometimes 2. And these are all showing you how many balloons I did in order to improve the situation. And I kept doing that, and only to show that we are getting better. So I decided to, okay, finalize by doing more proximal lesion between the two stents in order to improve it also. And this is how it looked after the deployment, indicating that there was a problem. The balloon was not, and eventually the balloon improved. And talking about without an IVIS, I can tell you there was a big piece of stone. So this is my first surprise. I did not expect to see the deformity of the balloon as I saw it in the proximal LED. And so I continued to work on it. You see it again, really impressive. And with very high pressure, I managed to release it. And then I went ahead with post-dilatations and decided to treat it with drug-eluting balloons. And this is what I did. And then I went back to the LAT, did more additional treatments and additional post-dilatations, particularly at the junction between the tip of the stent, as you see it here, and the beginning of the native vessel, because here the tip was actually under deployment, not under deployment, at least recenosed partially. And the additional improvement I could succeed in getting, and then I started drug-eluting balloons, and this is my distal drug-eluting balloon, followed by another drug-eluting balloon that I joined with the stent more proximally. You can see the extension of the calcium and the deployment of the drug. Then I went ahead and put the second drug-eluting balloon long and improved it. and then went into this stent, with the segment between the two stents, and did the drug-eluting balloon. And here is the drug-eluting balloon. And this is the drug-eluting balloon as it is. And I thought that this work is over, and actually it was. So here I am satisfied. I thought, okay, let me deal with the right coronary artery and see what is going on. The moment I put my wire, my aim was to treat the RPDA because the guy had apical inferolateral ischemia. And this is my smallest balloon, 1.25 balloon, and it did not move beyond the spot. I made all efforts with deep engagements, with back of the aorta support in order to get this 1.2 balloon to cross. Eventually, I did what I call piecemeal ballooning. Same balloon, but I keep dilating and pushing in the same place until I found myself making a partial advancement, then another partial advancement, and again and again, and still the view is reasonable. Okay, so I thought I'll continue. Let me try again. I here tried to get a little bigger balloon. Again, no crossing. I kept inflating. This is 1.5 balloon, then escalated to 1.75 balloon, and again I'm unable to cross here as well, and continued. Now bigger balloon, more proximally, and continued. And now with this advancement, I managed to cross. As I crossed, I started, of course, you noticed that the crossing was with the help of a guide liner, guide extension, and that was the only way. And then I restarted again the process of inflation from distal to proximal, and I kept working on it. It took me about 13 balloons, a couple of them ruptured, and then eventually managed to go beyond this stented segment and redilated. Every single step was extremely difficult to treat, and continued to do that. And now with bigger balloons. And of course, don't forget that I ended up using two IVL balloons. I was hoping to use three, but we did not have three. One in the middle, where the highest resistance was, and the second was in the proximal segment. And I kept doing this, and with the, I think this is the IVL balloon, and continued. And you can see there's a lot of recoil, part of it within the stent and part outside the stent. And again, continued to use my usual technique, balloons, and all of them, including eventually what you call, this is my last what you call IVL balloon, shockwave, and here is the final. In fact, you can see it again here. Sorry, this is a repetition. Yeah, this is my drug-eluting balloon before the result. I ended up not putting any stigma. And another drug-eluting balloon, and final result. So, what did I learn? What did I learn? That obviously not all angiographic images should be trusted. Apart from non-invasive imaging, invasive imaging, whether by IBIS or CT, non-invasive, I mean nuclear or other studies. Invasive imaging, whether by IBIS or CT. Don't forget that IBIS no way would have crossed, nor OCT would have crossed into this vessel. Of course, you can use FFR, AFR, QFR, etc., but no room for it in this case. It remains, however, that I face angiographic image, when I face angiographic images not of the kind, not even suggestive of a lesion, then in practical term, I'll call it a deceiving angiogram. What did I learn? Even when we are not ready for invasive imaging due to no crossing or not availability, we have to test the grounds. And what I did basically by introducing small balloon and unable to cross was probably what my test. As I proceeded, I faced inability with the smallest balloons, did RCAs, then I went to initially to treat the RPLV, RPTA, but I ignored it at the end and concentrated on the calcified segment of the middle AD with 2 stents and escalated, as I mentioned, scoring balloons, selection of supporting guide catheters, use of guide extensions to support stents advancements, sometimes deploying stent proximally before I deploy the distal can help to put if I needed to put stent, but in this case, I did not put stents. I tended to use intensive high pressure instant post-dilatations, and I use anywhere from 1-to-1 ratio to 1.1 to 1 ratio or 1 to 1.2 size ratio in order to optimize stent deployments at very high pressures. So use a stent boost or stent vis frequently to guide the following: stent deformities or fractures and under deployments. Yeah, I'm finishing. This is actually the one before the last. Positioning of stent edges to avoid out-of-stent additional trauma and dissections. Stent positioning at osteal lesions, particularly at critical locations like left main osteal, left main osteal LCX. Use of drug-coated balloons whenever you can. Why? Because to avoid metal jackets, and particularly in smaller segments, branches, and with that, avoiding metal jackets because it's definitely the worst scenario. So STI is the art of how to prevent future events. It's the art to do the least harm and best possibility to improve normalcy of flow with the less metal, more drug we get with coronary physiology better. Be careful with calcified lesions as they may lead to require debulking devices, rotators, shock waves, etc. And do not forget critical and life-saving role of covered stents, because this is a high risk for ruptures, and you can avoid mortalities by this way. Patient did well, and actually I saw him in the clinic. He's fine. Thank you.